So today, without further ado, patient-centered care, ePROs monitoring in thoracic surgery and oncology patients with Gita Mody, MD, MPH. Dr. Mody, welcome. Thank you so much for being here.
Thank you, Tim, and thanks to your team for getting this all coordinated.
Absolutely. No, they are phenomenal. So rather than read all of that, we're going to do our top five. So Dr. Mody is an adjunct assistant professor at the UNC Gillings School of Public Health with the Public Health Leadership Program. And she received an MD at Washington University School of Medicine in St. Louis and received her MPH in clinical effectiveness from the Harvard School of Public Health. And major research interest is in optimizing quality of life and other patient-centered outcomes in patients with chronic illness. Current and prior work is funded through grants from the National Heart, Lung, and Blood Institute, American College of Surgeons, and the Thoracic Surgery Foundation. And finally, number one, she is passionate about global equity in health and actively engages in training the next generation of clinical scientists from low-resource settings through her work in the Malawi Cancer Outcomes Research Program. And Dr. Mody, I understand you have just returned from Malawi.
Yes. As you know, I was there teaching and training. I appreciated everyone's patience as I faced some flight delays, and I'm so grateful to be able to be back and to do a live presentation to you and your audience.
Well, we are very appreciative for your making time on top of everything else that you're doing. So thank you. I mentioned that we would have the poll everywhere. This is just a mock-up slide, but ePRO is the abbreviation for electronic patient reported outcome. That's a true or false. I'll give you a moment to think about that. And there are our disclosures, which thankfully I no longer have to read in detail. I've flashed them up. You've seen them. On we go. And now here's the actual poll everywhere. So go ahead and respond, and we'll see your responses in just a moment. And Dr. Mody, let's take 5 or 10 seconds, and then you can let them know how they're doing.
Great. I'm really impressed with how this system works. I love the test question. What a great idea. And I'm pleased to see so many participants. It looks like more than 60 over there, with many logging in with the correct answer. ePRO, electronic patient reported outcome or outcomes. And I think we're probably good to go. What do you think, Tim?
I think we are. There's your first slide. I'll go ahead and get out of the way and let you take it from here. Thank you so much, Dr. Mody.
Sure. And as you know, I've got a number of slides. I'm very passionate about this topic. So if I start to approach time, you just tell me and I can move along.
Will do.
As mentioned, I'm Gita Mody. I'm an assistant professor of surgery over here in the Department of Surgery at UNC. I'm involved in caring for patients in our multidisciplinary thoracic oncology program. And I'll talk to you today mostly about my research work. I do want to tell you about funding I have. I serve as an unpaid consultant to Savan, which is an ePRO vendor, and have received some research funding, which is now completed from them. I have 3 main objectives, and the first, as in bold, is to describe the symptom burden of thoracic surgical and oncologic conditions and treatments. Related to that, we will then review the reasons and methods for patient-reported outcome monitoring itself. So that's when I'll introduce ePROs. And then finally, we'll discuss the implementation of PRO monitoring in thoracic patient survivorship care. During that section, I would love to hear from you if you are doing this type of intervention in your patient population, and you should provide us with any tips or tricks that you have, as well as any questions. So just extremely briefly to orient you to the clinical situation, thoracic surgery, so general thoracic surgery, non-cardiac surgery, involves all the other organs in the chest, the esophagus, mediastinum, trachea, chest wall, and somehow I left off the lungs, but that's obviously primary here. Well, with that, we can treat a number of chest diseases, whether it's emphysema, dysphagia, which is swallowing problems, reflux disease, tumors in these areas, tracheal anomalies, diaphragm disease, or even end-stage lung disease requiring transplantation. Now, with that heterogeneous of a problem set, we have many different ways we can approach the surgery. In the United States, in our setting, minimally invasive surgery predominates for lung resection, whether it's through standard laparoscopic, which is video-assisted thoracoscopic surgery, or using a robot assist, or even just this new innovation of one port. Through these approaches, we can perform various extensive pulmonary resection, be it a small wedge or a pneumonectomy, can remove the thymus, repair the diaphragm, remove portions of chest wall, lymph node biopsies, and so on. Why is it so important that we have all these procedures to treat lung cancer? Well, as you see on this slide, not only is it a leading cause of cancer in both genders, but also the leading cause of cancer deaths in the United States. While cases are decreasing over time, currently we still face 250,000 patients with a new lung cancer diagnosis annually. That is 12.4% of all of our new cancer cases in the U.S. 1 in 5 cancer deaths, mean age of 70 years old, but thankfully, due to reduction in smoking, earlier detection and treatment advances, we can start talking about survivorship care. I just want to point out that one of the reasons why lung cancer is so leading in the causes of death is because that the cases largely present, the patients come with distant disease. It's relatively asymptomatic until it gets to an advanced stage. So with more than half presenting with distant disease, we have much to do to improve stage migration using screening and other tools. Oh, I didn't do that. Did I do that? Tim, should I pause here?
Let's see. So yes, is that where you wanted this question?
I think so. This is a sort of an opener. So I want to see where the audience knowledge is. And the question here is, what is the most common treatment for early stage lung cancer? This is of course in the American setting. And by early stage, we mean stages 1 or 2. So maybe a small tumor that presents on a screening scan or incidentally. And we've got 3 choices here: surgery, radiation, observation. The answer will come. I was just struck that there were already some entries, but maybe the poll everywhere captured it quickly. So give a couple.
Yeah, it looks sometimes it gets excited and jumps up to let folks in early. Sorry about that.
Okay, no, not at all. I'm so happy actually, because I see majority are getting the answer right. The most common and actually the gold standard for stage 1 and 2 patients in our setting is to perform surgery. Okay, so here's the answer to the question that was placed there to assess knowledge. And you see it's quite an overwhelming majority. Now, obviously, the patient should have no other risk factors that can't be modified and otherwise be consistent with their goals and values. The majority of our early stage lung cancer patients undergo surgical therapy. And I put this slide here mostly to motivate why a thoracic surgeon is working to improve patient-reported outcomes in lung cancer patients. So as we've touched on, the lung resection can be done not just for treatment, but also for diagnosis or palliation of lung cancer and other thoracic conditions. Currently, there are more than 80,000 lung resections performed every year in the United States, with an increase in the most common procedure, which is lobectomy. Now, there are many approaches to lung resection. The most common is to do either a posterior lateral thoracotomy or minimally invasive surgery. Currently, more than 80% of lung resections would be done minimally invasively. We can also approach the lung through sternotomy, but it's much less common and usually reserved for upper lobe disease. The extent of lung resection is determined by the tumor and its location. As you can see, a very peripheral tumor may be removed by a wedge, which is much more simple and easy to tolerate. Something slightly larger may be removed by a segmentectomy. There are 18 segments in the lungs. Or lobectomy, 1 of the 5 lobes would be removed. Finally, a very central tumor may require pneumonectomy. I put this slide here so that you can see not only are there a range of incisions, but there's a range and amount of lung tissue that's involved. And so quite a variation in the symptoms that may be experienced postoperatively. This is a really important trial. This is done in European centers. Randomized patients who were referred to lobectomy to either an open or a video-assisted approach. These patients were followed to the primary outcome of physical functioning, and I'd like to show you the results. which clearly established video-assisted surgery as the standard of care. Not only were there fewer complications, no differences in the adverse event rate, a shorter hospital stay, lower rates of readmission, and very similar progression-free survival and overall survival rates for the patients with lung cancer enrolled, but also the quality of life results were better. There was less pain on the visual analog scale, less opioid use, better physical function as measured by the EORTC, which is widely available cancer-specific quality of life scale, and improved global health status. So, as I said earlier, thankfully, even though there's still a number of cases and it's a leading cause of death, the rates of lung cancer are decreasing and survival is improving. So that's really where we are when we start talking about the need to longitudinally monitor patients' health-related quality of life. So this was a really nice study done over the course of 1 year where patients got repeated surveys, again, using EORTC. And as you can see, expectedly, at 1 month, global health, the various domains, including physical functioning, all reached their low point. There's steady improvement, though not a total return to baseline. And I think that's very important to know. The quality of life doesn't fully return to baseline even at 12 months. So there's the dip at 1 month. Now let's take each specific symptom, since that's a major focus of my work. I think it's important to show that symptoms peak at 1 month. They do improve, but even out to 12 months, we still have dyspnea, shortness of breath, persistent fatigue, that's that dark blue line, and even pain. So even though the incisions are healed and the wounds themselves are not a source for acute pain, patients may continue to have some above baseline pain for as far as 12 months after the surgery. Okay, so this one, and I can go back to the slide as needed. So here's the question. Shortness of breath is a short-term post-op symptom after lung cancer surgery. So let's take a look back at the slide. And dyspnea is measured here. So let's see how we're doing in the poll. Well, I can't tell how many answered, but everyone got it. Maybe it's too easy. I think it's really important, right? So you have a patient who's coming to have a curative surgery that they would elect to have it, but they would certainly feel better counseled if they knew that they may live with some symptoms afterwards, and then we certainly have support programs to help with that. Okay. This is a study done by a friend and colleague of mine at UCSF. The team qualitatively assessed patients for their own priorities in terms of their healthcare quality of health-related quality of life. So these are patients with lung cancer who'd had surgery, and obviously asked about the domains of physical health, which we've already touched on some of those symptoms: fatigue, strength, sleep, pain, including neuropathic or breast pain, which is another way people are saying the chest pain from the surgical incisions, and lung function. Those are evident from the study I presented. But let's look also at the emotional health problems. People's emotional energy improves, but they're still sometimes suffering from anxiety, fear, frustration, and loneliness in terms of the emotional support. So these were the patients with lung cancer, their own report as to what was important to their health-related quality of life. So it leads me to like the overarching question in my research work. When, and maybe also how, should health-related quality of life be measured? Should we measure it in the pre-op period where a patient has dyspnea or cough from their lung tumor? Immediate post-op period where they're suffering from the immediate recovery from surgery once they're ambulatory and a little bit more on their own? Or in the post-op and surveillance phase where they come to the clinic to meet the providers? I would argue that we should measure health-related quality of life across this entire spectrum. So how do I know that? Is from prior work where I've interviewed patients who've had thoracic surgery about a year after the procedure and analyzed their interviews according to themes. Found 3 main themes were observed, and these are very consistent across other types of morbid interventions. First, the patient said there was an unexpected duration of the physical recovery time, and that fits with the quality of life trajectory we saw And that was with minimally invasive surgery. I'll say that study that followed them for a year. They did report they did eventually return to their baseline physical functioning. Now, even though we saw on the graph that might not be true, there are some concepts within quality of life research that suggest that people adapt or adjust. And finally, they did report an improvement in their emotional health-related quality of life, and that I would guess is owing to the certainty of being treated for the cancer diagnosis. So it puts together sort of a model of understanding how do the outcomes thoracic surgery patients experience contribute to their post-op quality of life, and also how do their expectations, if they all said, going back a slide, there was an unexpected duration of recovery. Well, they got better, but it took a long time. So their expectations were not quite what they experienced. So how do the expectations of patients contribute to their post-op quality of life? And as you can see, I think there's a lot of things that go into all this, not just their pre-op functioning and their post-op symptom control and what they experienced around the time of surgery, but also how they adhere to a program of care. And we'll talk a lot about adherence to ePRO monitoring as we go on in the slides. So another way we've tried to answer what's going on with lung cancer patients, besides, I showed you the colleague, Dr. Brown from UCSF, who talked to the patients, is to do a systematic review. My current chief resident and soon to be colleague surgeon, she's just been hired on staff, Dr. Merlot, has done a extensive systematic review examining studies that reported on health-related quality of life after lung cancer. You see, we found after combing through a large amount of literature, 153 articles focused on quality of life in this patient population. We actually broke that down further and have several ongoing studies, but I want to highlight one that reached publication about the symptom burden. What is a symptom burden after lung cancer surgery? We learned so much in doing this work. The first learning point was that look at the larger number of articles that are published in just the last decade about this topic. Again, as the survival curve goes up, the studies and emphasis on quality of life is emerging. Next, look at how many different ways there are to measure quality of life. Most common was the short form 36, but also the EORTC, some other non-cancer specific scales. And all these questionnaires and instruments were listed, included in less than 5 each of those 54 included articles, suggesting a lot of heterogeneity in the research and not a clear answer for how we should do this in practice. Key findings, symptom burden is high before and after surgery. Pain, dyspnea, cough, fatigue, anxiety, those were the most studied symptoms and may reflect how common they are. A number of studies pointed to pre-surgery symptoms as a risk factor for symptom acuity and persistence after surgery. And finally, that symptom burden is itself a predictor of post-op quality of life. So now that I've talked to you about what thoracic surgery is, obviously what we treat with thoracic surgery and what the post-op symptoms or side effects are of thoracic surgery, let's, review reasons and methods for the patient-reported outcomes monitoring as part of this patient-centered care lecture. So why patient-reported? And who should be reporting on that quality of life? They agree when it should be done throughout the continuum. So let's look at work done by Dr. Sam Sykert, who's here at UNC. This is a really nice study where patients at risk for lung cancer were asked to use the comparison of health utility scores scale. It's like a standard gamble to talk about common post-op conditions. So if you look here on the table, the utility score from 0 representing death to 1 representing perfect health for various outcomes. So look, pneumonia requiring 2 weeks of hospitalization is rated better, like a preferred outcome to something such as unable to walk without stopping, reducing current activity level, oxygen dependency, or nursing home. While we measure pneumonia rates and need for intervention after surgery and ventilators as our standard clinical outcomes, patients put a much higher emphasis on their independence and physical functioning. No surprise to those who are listening to a patient-centered care lecture. So again, the who. Should we have clinician-reported outcomes, patient-reported outcomes, or some combination? It's important to note studies do show that clinicians not only may not report the same symptoms, but would say, for example, for nausea, if it's less severe than a patient may report about themselves. So these patient-reported outcome measures, you're hearing about it very commonly, originally actually started as guidance from the FDA as to how clinical trials should measure not just clinical outcomes, but also the patient-reported outcomes. These are dictated to be measurements based on a report that comes directly from the patient about their own health condition without amendment or interpretation by a clinician of the patient's response. So this is all well detailed in the current FDA guidance. But what is it? What is a patient-reported outcome? So we get it. It's a measure that comes directly from the patient, but it should be developed not only with patient clinician input, but also evidence for its validity and its reliability so that we can use instruments that are more consistent and have a way to incorporate them in our practice. So, even in surgery, PROs are an emerging and important piece of the pie. This is from our American College of Surgeons National Surgical Quality Improvement Project, the large database that looks at very traditional things like length of stay, pneumonia rates, DVT rates, wound infections, mortality, but also after a new pilot study is including patient-reported outcomes as a additional viewpoint on how to measure quality. So additional thoughts about PROs. This is a slide from a colleague of mine here, Dr. Angie Smith. The lowest bar is that it measures the health concept that's correct for the patient by the patient's own report. But a much higher bar are those items for validity, reliability, and the psychometric evidence. I think this quote is just so important, and it comes from one of the pioneers in the national health system on using patient-reported outcomes for cancer care there. Well, for patients, clearly, there is much more to success than an alive or dead outcome or complication or no complication. How often have we heard, all right, the doc said my hip replacement went well, but I am now housebound. Or he or she says I have good flow in my vascular bypass graft, I still get pain after ambulating for a short distance. So it's sort of a more complete picture of what's happening. It's not just how the surgery has resulted clinically, but also how the patient feels after a surgery. All right, well then how do we measure it? And we talked a little bit about at the beginning, there's many instruments. In thoracic surgery, some that we like for symptoms are the St. George's Respiratory Questionnaire, commonly used for COPD and bronchial conditions. Functional status, and there's even a patient-reported functional status instrument. We've already talked about health-related quality of life measured by the European Organization for Research and Translation in Cancer. There's some disease-specific instruments that go along with the overall quality of life questionnaire. This one, as you see, has 30 items. There's a lung cancer-specific module with 13 items. Even self-efficacy can and should be measured by patient reports. So there's a PROMIS self-efficacy scale, which I think is very interesting. I'm currently using, as are other researchers at UNC and clinicians, the patient-reported outcomes version of the common terminology criteria for adverse events. Any of your listeners who are in oncology know about the CTCAE, which is available through the NCI. This PRO version allows researchers, clinicians, and others to go to a data bank and pull out questions that have already been tested for their readability, their validity, that are specific to cancer symptom, but can be nuanced to what the patient is experiencing. So what are these small initials on the side? Let's take abdominal pain. There's a question in the bank for how frequent, how severe, and how intense. As you see across the various organ systems, these symptoms are asked according to frequency, and the standard library makes it very useful to keep things consistent across practices and studies. So this is a theoretical model of how I think an electronic patient-reported outcome works. Now, I know I haven't defined it yet, but I'll show you some slides that show what an ePRO is. This is what we think is happening. First, the ePRO system would detect a symptom, the patient's reporting it. Then the provider gets an alert and contacts the patient. There's a number of things that are happening in that context, and I've learned it through interviewing many patients who have participated in ePROs. One, reassurance on an expected recovery. Two, complication detection. We've even picked up pulmonary embolism in a patient who reported tachycardia and shortness of breath in a week after surgery, after they're home. And then 3, symptom management. Sure, we send patients home with a narcotic for pain control, but is their pain very well controlled? Are they having some new problem like constipation? So there's a number of things that happen in that interaction. It's a very important, it's a complex one. These are the things we're able to measure. We show reduced symptom burden, fewer readmissions to the emergency room and the hospital, and improved survival. These are from national trials outside of thoracic surgery, but very informative for my work. So, okay, what is electronic patient-reported monitoring? It's interesting. You see, I wrote paper here. Well, how would that work? You could hand a patient a form, and if the form is filled out and can be transcribed to electronic system, it gives a way to deliver the PRO to the clinician. Of course, we can use a kiosk, tablet, even their home phone through a pre-recorded phone call. It's called interactive voice recording, kind of like a robocaller calls from the cable company. They still do that. And then even a phone call, a researcher could call, take down the PRO. Another colleague over at Gillings, Dr. Angela Stover, is working on a very interesting study where her pharmacists call patients about chemo symptoms and enter that into the system. But ultimately, an ePRO would eventually deliver the message to the clinician, whether it's through an alert by email, Epic in basket, or text message, or reports that are handed out and show a graphical display of symptoms over time. So again, some little cartoons that'll help us get it. What's a standard approach to post-op symptom monitoring? You're very familiar with this from your practice. The patient comes to the hospital or clinic, they run out of time, they forget to tell their provider, even though they look very friendly. Then they go home and they're kind of reluctant or have problems, phone tree kind of situation to get to the provider. So ultimately, this interaction of responding to the patient's issue is more reactive and not in real time. Here's an alternative. Let's just assume the patient's going to have something that's going to come up. Send them a reminder from a software system and ask the patient to report the symptom into the software itself. Then the provider is alerted and allows for a report to be generated, and finally for them to come together about the issue in a more real-time and proactive approach. This is what we like. How do we actually do this? So we've designed a survey, pull out pro-CTCA questions that are common. We use the literature review to guide which ones they would be, and send the patient a reminder on the web or by a phone call. Can you fill it out and answer how much is cough interfering with your activity today? Or nausea for patients receiving chemotherapy. And again, for patients who are less tech comfortable, so they may be able to do it. They might have an email, they may have a computer, but they may not fit their routine. It may not be part of who they are. Getting a pre-recorded phone call may improve things in terms of access. So where's the evidence that PROs are effective? And that comes largely from advanced oncology. Dr. Bosch, who's a mentor of mine and the head of the cancer hospital here and many innovative research programs, designed the PROTECT study. It was a 52-site trial that was national, and centers were randomized to using ePROs versus usual care. These are community centers, to be clear, and each site enrolled patients with advanced cancer who were getting chemotherapy. Typically, patients were with breast cancer, lung cancer, no indolent hematologic conditions were enrolled because of the lesser symptom burden. So for my part in this research, I analyzed the proportion of lung cancer patients who were undergoing the monitoring with PROs in Dr. Bosch's study. Again, they got weekly reminders to do a survey about their symptoms, had an opportunity to write in symptoms, and as you see, the providers at their center got an alert for severe, very severe, or increasing symptoms. Patients were asked to complete a survey for us so we can understand their satisfaction with the system after 3 months of participation. So I just will give you an overview of those patients. The lung cancer patients compared to the other cancer type patients in PROTECT were a little bit older, had worse performance status, more comorbidities, but were similar in other regards. And I thought it would be interesting to know for the patients who were doing the pre-recorded phone call, the voice recording versus the web-based, how they may differ. Interestingly, their age wasn't different, gender wasn't different. not even education level, but their use of computers prior to the study differed. So obviously less frequent in the group in terms of computer, email, or internet use that chose the phone call versus the web-based. So if we only screened on do you have the device and can you do the study, we may be missing something about their comfort level. So asking about device frequency gave us some insight into that. So this graph just shows how feasible it was for patients, even patients with advanced or metastatic lung cancer undergoing chemotherapy for treatment. The percentage of people completing their PRO survey was greater than 80% throughout all 52 weeks of the year-long study. That's, I think, tremendous. And really importantly, not only could they do the surveys, but also the patients who had alerts, so severe, very severe, or increasing symptoms, were relatively frequent. For the first couple weeks on study or so, they had about 50% of patients saying there was some problem. Now, as things moved on, as the patient learned how to manage their symptoms better and maybe things settled down in terms of their disease control, still 30% of patients were reporting some kind of potential symptom needing management on this ePRO study. And not surprisingly, very consistent with the systematic review, pain, poor physical functioning, chemo-related symptoms, and even depression were really common and lasted, sometimes for weeks on end in the study. I think the key here is that the provider would know before the next planned follow-up visit, right? So if they're being seen on every chemo cycle, maybe every 3 to 4 or 6 weeks, at least their pain can get reported at week 1 instead of waiting until it's out of control or the patient thinks to call. So these were the write-ins, and very similar to our systematic review, pain was predominant, as was shortness of breath, cough, and some non-cancer specific symptoms like back pain. So what happened with all the information, right? I'm telling you that 30 to 50% of patients generated an alert depending on which week of the study. The nurses received those and handled them in a variety of ways. By majority, they either told the patient on the phone how to self-manage it, change your hydration, take some Tylenol, or told them, okay, at the next visit, we'll know about it and we can plan to address it. So those are the 2 most common strategies. But other strategies that were reasonably frequent were actually changing a medication, expediting a clinic appointment, sending them for an X-ray or CT, or even in almost 1% of cases, sending them to the emergency department. I think this is important. Yes, the patient may have eventually called, but very proactively, the nurses and nurse practitioners were asking the patients to change their approach to their current care. So what did the patients think? Okay, after 3 months of experience, they did the survey. And as you see, they all thought the time for the very short survey was reasonable. Some thought that the questions could be changed, but most thought they were really easy to understand. The whole system was very straightforward. On the whole, the questions were relevant to them and improved in 65% of cases, improved conversation with their doctor or nurse. Majority of patients felt that the providers were using the information, allowed the patient to remain more in control of their care, and would recommend the system to others. So when we put together the strongly and somewhat agree team, 87% would say that their peers should use the system. So what are the conclusions from analyzing the lung cancer patients in the national trial? First, this was feasible. There is a high symptom burden. The providers did respond. And of course, we know we need some real world experience and implementation strategies, which is what my current work is on. So here we are discussing implementation of PRO monitoring in thoracic patient survivorship care with an emphasis on thoracic surgery, since that's my practice. So we've got it. The PROs are valuable to individual patients, maybe even the providers, but really they could be extremely valuable if embedded in the EMR to a number of stakeholders. The administrators, the hospital systems, and even researchers and payers. So we think it's really important to study the implementation and understand the multi-level stakeholder input into how to move forward. We use the consolidated framework for implementation research, and in this there are 5 domains. The characteristics of the ePRO package itself. Like, what's the design of the system? How is it explained to people? The outer setting, which can be considered not just the clinic, but also the patients, the needs of those groups. The inner setting, the clinic itself, the provider's characteristics, and then the whole process around it. And so, again, from Dr. Stover's group, this shows how an ePRO system is looked at in the context of CFR. So, again, the system picks up the symptoms, enhances communication, improves symptom control, and reassures folks. It's been shown in thoracic patients, symptom burden goes down. In oncology patients, the ER visits are lower, survival is better, quality of life is improved, and physical functions improved. Patients also report increased satisfaction with their care team. Now, whether we believed or not the model and the data, there are a number of groups, as listed here, from CMS to the NIH and the FDA, who are advocating and may eventually mandate PRO integration. It's coming, and there's actually a number of resources available, as well as consultants, to help practices figure out how to bring PROs to their quality assurance. So here at UNC, we've developed a variety of approaches. As you know, we're a state-owned not-for-profit medical system affiliated with our School of Medicine, which is a leading academic center. We have a tradition of public health and service within our community and beyond. We have this thoracic oncology program. It's actually the country's oldest multidisciplinary thoracic program. And we assess patients who have the need for care for lung cancer, mesothelioma, other thoracic malignancies, and include a comprehensive slate of multidisciplinary personnel. I'll walk us through our studies. And Tim, what time do you want me to wrap up so that we have the Q&A, just so I make sure I do this in a timely way?
Sure. I would say no later than 12:55.
Oh, okay, fine. So it's the timeline's coming up. And as you see, this first study started in April 2020, right in the middle of COVID, not even on the heels of it. But yet we enrolled 113 patients. I'll tell you about our experience. That moved us on to a study completed last year that really looked at the implementation characteristics of the ePRO. Currently, we're doing a user-centered design project where a PhD candidate has worked with my colleague providers and our patients to understand in real time what they experience when using the ePRO. And next up, we're going to launch a large feasibility pilot this fall, followed by an enhanced pilot and rolling another 100 patients in 2024. So the first study. We recruited patients from our clinics. I have two colleagues who also see patients. We do more than 600 surgeries together a year. And over 2 years, we brought in patients who were able to do the web-based pro-CTA survey that is specific to thoracic surgery. We did this via one of our research cores here at UNC, the Pro Core. They're fantastic. They do consultations and are very happy to help researchers and even practices establish their approach to ePRO monitoring. We had a schedule that's very similar to the ProTech study, where automated email reminders were sent to patients, and then the study CRAs would call as needed to encourage patients to complete surveys. As you see, we had a 56% agreement to participate rate. We actually brought patients into two arms and analyzed the second arm as a sub-study, where those patients not only did the PRO, but the provider also got an alert. In total, 99 participants began ePRO monitoring after discharge from thoracic surgery. This was the schedule for delivery of surveys. It was very intensive. My thinking at the time was, well, we're monitoring the vitals every 4 hours. Should we not look at their symptoms after they leave every day for at least 2 weeks until the clinic visit, and then follow weekly until 90 days of follow-up? We learned a lot from this really intensive schedule, and I'd really like to share that with you now. First, the characteristics of the two-arm groups were roughly balanced in demographics and even clinical features and the surgeries that were done. Next, what were the participation rates? We actually broke that down. We looked at the 2-week period immediately following discharge and then looked at the several months after discharge. In the beginning, we had about 50% of patients doing at least half of their surveys. That's these two boxes together. But as time went on, more patients participated. Now, obviously, the survey rate was less frequent, but patients were also feeling better. And our interviews with the patients really helped us understand what was going on there. We did want to see what were the characteristics of patients who had the highest completion rates compared to patients who did not. And we actually found that a couple of features, first being married or partnered, predicted better compliance with the ePRO system, adherence. And the next, being a non-smoker, predicted improved adherence with the ePRO system. So what about the interviews? This is where we really learned a wealth of information. We did a purposive sampling of patients from the overall study of 99. And these are the characteristics of those who were interviewed. There were 16 interviews done. We determined a number of themes which we organized according to a theoretical framework for behavior change called COMBI. COMBI stands for capability, opportunity, motivation, and behavior. And I've just highlighted some of the results from a paper that's in progress about what the patients were telling us. So first, they did tell us symptoms and physical functioning during their recovery were barriers to just doing the ePRO. That's interesting, right? Because the ePRO is meant to capture the symptoms and hopefully make them feel better. But there were days where they were just feeling awful and didn't complete the survey. But it was because of how they're feeling, not because of their motivation. So this led us to think, after going through those interview results, that daily might be too often, and the patients were doing their assessments were feeling a little better. So we want to devise a strategy to help assist them during the early period when they are feeling lower and not ready to do the survey. Next, while most patients, of course, they were selected if they were able to participate, but it still meant that they had to have adequate access. It couldn't just be the computer existence alone or the email or the internet connection. So if someone really relied on, let's say, their child for their email to log in, and then the patient's had surgery and the child is busy again with working, or connectivity is present but really slow, they may not be motivated to do or have the opportunity, honestly, to do the system. So maybe we should offer the telephonic, even if the patient would say they have internet, and go from there. That was our conclusion. So a few more themes related to the opportunity to participate. I thought one was important. So it was easy. That's theme 3, but the patients really did prefer if their surgical care team, whether it's surgeon or nurse practitioner, engage them about the ePRO participation. So if the surgeon in the office were to say, can I send in the health navigator to enroll you to the ePRO, they'd be more likely to agree to participate than if you just kind of had a cold call about participating. It gave it a legitimate feeling. And that led me to say, okay, we've really got to nail down how we get the busy clinicians to engage patients on the ePROs. So there are a few other themes related to motivation to do the surveys. Sometimes the questions just weren't right for the patients, a little irrelevant or repeated. And that leads us to say we should give patients an opportunity to shorten or tailor the ePRO. The patients reported that sometimes there's lack of clarity on how the symptom survey they had to deal with what their experience actually integrated with their routine care. And that led us to a lot of learned lessons about how to introduce the ePRO, even though it's in the context of a research study, to make it clear how it links to what the providers are doing. So we tied it into the perioperative teaching and discharge process. And really importantly, I think the patients found that it helped with their own education about the process, increased their awareness of symptoms and recovery with ePRO use. So that led us to our current work. And I'll try to go quickly through that. But you see, we use these brochures to tie everything together for the patient, to tell them what would be happening. We did enroll another 40 patients and are doing interviews with another 15. In the enrollment, we really learned that having preclinical or periclinical staff involved in recruitment was important because it ties it to the clinical process. And helps inform the patient about how it all may fit together. And we also saw improvements with the revised recruitment materials. Okay, so we're already looking at the next question, and this is sort of a what's your opinion thing, though I have an opinion about what the right answer is. So which barriers are affecting ePRO participation and implementation in your clinic? And, maybe some people will say, oh, we actually got it. We're already doing ePRO monitoring. But I have a feeling many are going to say there's a lot going on, a lot of reasons why ePROs may be harder despite the evidence for their benefits than it seems. Is your front desk able to help give the log-on information to patients? Do your docs or other APPs look at the data and use it? Do the patients think it's going to help them? Or is it some combination of all of that? Well, I agree. I think there's always a multi-level barrier that can be addressed. And we have found all of these things are important to consider in the implementation plan and have come up with new improved ways to address them. Okay, I guess that's the question. All right. Well, I think I'm doing all right. I'd like to acknowledge the care team. Without them, this couldn't be possible. So my two colleague surgeons are APPs. The NPs are Lauren Helm, Bernice Newsom, and Julia Coleman, whose newest care group is a nurse navigator. These two in particular respond to the PROs that the patients provide and are the form of that connection that the patients are so deeply grateful for. Also really thrilled that my residents who are training to be future cardiothoracic surgeons are learning and engaged in patient symptom management and post-op quality of life. So funding acknowledgements we've already been through, and the slide contributions, as well as I could not do this without UNC Procore, Antonia Bennett as the faculty director, and Matthias Johnson as the overall technical lead. They've really been tremendous in their support of this work. We provided a lot of information, and here are some of the references which I think have been made previously available. And I really love for you all to check out our lab website and to give me feedback, comments, questions, ideas. And I think that's where we are now. Tim, if you agree, I'll leave those demos in case any questions come up.
Okay, I do indeed. So let me go ahead and advance a few more slides, and we'll get to where did you want to show these Procore demo
Well,
slides?
I bet some questions would come up about, well, how do you actually do it? So this is what the patients see. Okay, hey, you're getting the survey. This is how you access it. This is, if you have a true emergency, you must go to the emergency room. And these are the physical functioning questions and overall ratings of health and so on and so on. I just gave a few examples.
Great. Thank you so much. And then so we do have the poll everywhere open for questions. So I want to encourage our audience members, go ahead and share your questions. Again, this is anonymous. While we're waiting for those to come in, I had one. So what factors might cause a patient to over-report on a symptom or to underreport, or I was just curious, what are the things that might make that difficult or may not make that as authentic as you would want it to be, whether that's embarrassment about answering a question or an investment in the success of the doctor or a whole host of other things. And so what are some of those, and then what do you do to try and help counteract those?
Great and really insightful. So the number one reason why patients say they don't tell us about what's bothering them is they don't want to bother the provider. Understandable, but something that almost breaks your heart when you hear it, because you want to be there, even when we can't. And so reducing those barriers by making it something that's automated, that we've said out loud, we want you to do this. Perhaps just shy of expect you to do it because it'll help us deliver better care to you. That is a profound motivator for patients. Yeah. In terms of over-reporting, that is very intriguing. And we do find sometimes a voice can get amplified. If there's a system available, maybe we just hear on an ongoing basis. There's a training component to implementing the ePRO, which I haven't touched on because my future work will really blueprint that. And that's to train the nurse navigator, nurse practitioner, surgeon, whoever's going to be involved in reviewing it, is what to do with repeated alerts about the same thing. I mean, it could be someone's chronic knee pain because the weather is not so good today. What it involves is some prompts and snips. Discuss with the patient. We received this alert about your issue. Tell me more about it and how you'd like us to handle it when we get those alerts. I think that's a great way to coach the team on how to handle the patient's engagement without limiting the possibility that they feel like there's a two-way, communication going on. We found that really helpful.
Gotcha. Great. Thank you so much. And we do have some more questions starting to come in. Have you tried any of the tools that MyChart offers?
Thank you for that question. We in my practice have not used MyChart as a tool for collecting the ePROs. However, in my last study, we did ask our patients about their engagement with MyChart and whether they'd be interested to see their data in MyChart. So if they were to answer the questions and they could see them over time, the answers are split. Some of the patients really do want that. They want to use the MyChart and to track themselves, and some don't. And I think that just reflects to the differences in personality and healthcare behaviors. We're very interested in trying that in the future.
Great. Thank you. And thank you to our audience member for that question. Here's another one. If the patient marks seldom or never for device frequency, what is the percentage completion of the ePROs? And does the team do anything differently for these patients?
Terrific question. So the seldom or never for device frequency was linked with the lower rates of completion, specifically the less than 50% group. And in the next study, which starts this fall, the team will actually get an alert for a patient who hasn't completed a survey. So instead of only alerting on patient has a problem that completed the survey, we are also providing a second alert for, and the survey was missed. So there can be a tuning in of a patient who's not adhering and may or may not have a problem, but an opportunity to reach out to find out what's going on there.
Great. Thanks so much. And here's another one. How long does it usually take to fill out the surveys?
3 questions in a minute. So we're now down to a 12-item questionnaire. A lot of patients get really used to it and can just do it in less than 5.
All right. Thank you. And thanks to our audience. We're getting lots of great questions.
Yeah, I love these. Very practical, really on point.
Yeah. Has your team utilized Epic MyChart for conducting ePROs? If so, can you share the experience? How can we integrate ePROs effectively with provider workflow to balance and gain buy-in? Is there a way to prioritize symptoms to prevent provider alert fatigue?
Great. These show that you have some experience with doing it. So we are working on a new project. My colleague, Dr. O'Leary, is a postdoc in my lab group, and she has expertise in process mapping, which is an implementation science tool used previously in screening programs. We are process mapping the ePRO system within the larger post-op care system, and that will help us understand how to tie it to the existing context. So that's coming. And is there a way to prioritize symptoms to prevent provider alert fatigue? No one's hit on the magic answer here, and this is why. In again, the ProTech study, nurses were asked, well, if we could turn off some alerts, would that be good? And in fact, when given the option to suppress some alerts, the nurses did not prefer that. So they do want all the information. But I think one way to move forward is to consider a grading: high priority, medium priority, lower priority. And whether that's going to come from the patient themselves, which is a possibility, or through an algorithm yet to be developed, I think AI could be part of that future there.
Great. Does your team provide any assistance for a group starting up with ePROs?
So while I'm happy to individually consult with anyone, I think the best resource for this will be through the ProCore. This is an emerging thing. There's been assembled. So ProCore is Patient-Reported Outcomes Core at UNC. They do have contact information on the website. And there's now an advisory board that's trying to, and I'm part of, tackle exactly that question. Is that, here's a practice or a group that actually wants to bring it into clinical care. How can we help with that?
Gotcha. And we are running out of time, so I think we're going to take one more question. I apologize, we can't get to all of them. For patients without partners, would there be a need for additional navigation survival support personnel at the facility? How do you get administration, BU? I assume that's buy-in would be the best of that.
Right. No, I think that's the question of the day. Yes, I think nurse navigators or digital health navigators will be a solution to this. There are practices. There's a group in Boston that's working on a digital health navigator training program. Until we have administrative buy-in, which will be only presumably by demonstrating improved outcomes that are cost saving, I think using community or lay support will be an answer to how to facilitate those patients who don't have their partner.
Great. Thank you. I want to make a few closing remarks. We want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Benny Obore, John Powell, Oliver Marth, Andrew Dodgson, Nadja Brown, Patrick Muscarella, and Lauren Lowe for all of their hard work on this and every one of our lectures.